In this interview, I'm joined by Dr Caroline Van Damme, adult psychiatrist and family and systemic psychotherapist specializing in the psychosocial rehabilitation of patients suffering from chronic psychotic disorders, and co-teacher of Tibetan Buddhist guru and Sowa Rigpa Dr Nida Chenagtsang. Caroline discusses the cultural complexity of being raised in Belgium, how an early interest in the mind saw her train as a psychiatrist, and the reasons for her specializing in chronic psychosis. Caroline also recounts her first encounters with Buddhism, including a meeting with a mysterious Lama, and the story of her collaboration with Dr Nida Chenagtsang to train counsellors informed by both Western psychology and traditional Tibetan medicine. Caroline draws on her professional experience to reveal rapport-building skills for clinicians, as well as discussing religious experience as a form of psychosis and the pros and cons of the religious mind. So without further ado, Dr. Caroline Van Damme. Dr. Caroline Van Damme, welcome to the podcast.
Thank you. Thank you for inviting me.
Well, I'm so delighted to be speaking with you today. And so much that I want to ask you about and so much that I'd like to discuss with you. But perhaps we start with your biography. Could you say a little bit about your upbringing and your early education, the context of that, and how it was that you went to study neuroscience at Brandeis University, USA in 1995, which, from what I understand, ignited a passion for the human mind and its relationship to the brain. And then, well, let me not spoil the rest of the story. From there, it gets very interesting indeed. So can you say something about your upbringing and your trajectory through your career?
Okay, well, yes, so actually I grew up in Antwerp, Belgium, not far from Antwerp. And my family is actually, Belgium is a very complicated country, and you can see it in my family. My mother Belgium is divided in two parts, sort of, and then Brussels, which is a third part. So the northern part is the Flanders, is a Flemish part. My dad is actually from Flemish origin, and my mother is actually from the French part, from the southern part of Belgium. So, but my paternal grandmother was also French speaking. And so my father grew up bilingual. My mother grew up in French, and when they got married, they moved to Antwerp for my dad's work. And so I grew up speaking French at home and Flemish in school. And because in Belgium, there are quite some tensions between the two communities. And things are even more complicated because historically French was considered the language of the elite. So even in the Flemish part, Flemish people who were from the elite would speak French, actually. And so there are a lot of complicated still today in Belgium, a lot of tensions between the French and the Flemish. And it has also to do with this whole elite thing that, you know, a lot of Flemish people feel that they have been oppressed by the French because even the Flemish elite were actually speaking French at home. And so you can see this whole thing was also there in my family, and there were this whole complicated mechanisms going on that were not, you know, were above me, where I had nothing, you know, it was inherited from my family, you know, from my parents, from my grandparents. And so in school, of course, I went to a nice, good Catholic girls' school in the center of the city, and we had religion classes. And there you would hear teachings that, you know, everybody should be equal and everybody should love everyone the same way. And I could very quickly see that what I heard in school and what I heard from religion classes was not really the same as what I would see in reality. And I started, you know, to get very interested into what's going on here. Also, the Catholic religion was also something that one way I was drawn by it. I have not been traumatized by Catholicism or whatever, but, you know, there was also this whole concept of everything you do, whatever you do, you are bad anyway. So we needed to go to confession. And when the whole class had to go to the priest and we had to say what we had done wrong. And then I said, I don't know what I have done wrong last week. And they said, you must have done something wrong because everybody has done something wrong. And so I invented actually, I invented stories to please the priest, and then I would lie actually. And so, it was this all those complications. I started to, wonder what this all about. And so when I was an adolescent, I started to go to the local library and get books about Buddhism. I got very interested in Buddhism, but of course the books in the local library about Buddhism, there are not so many of them and they don't go very deeply. But I was, this idea of Buddhism, it seemed something different, another way of looking at things. They didn't talk about a God who was deciding about everything, and that the injustices could be explained by karma. Whereas how I would see it is, in the Catholic way was you get born and then, there are injustices. Some kids get sick, some others don't get sick. I also had my sister who got very sick when she was young. She had a very bad cancer. And so I've spent a few years going in and out of the hospital, seeing my parents, very worried about my sister who might die because it was a very advanced cancer. So then those other kids who were there in the hospital too, they would end up dying. And my sister, she healed, she got completely cured, and it was considered some sort of spontaneous healing. So my sister is still there. She has a family now and she's very happy. And so how come there are so many injustices that, some kids really suffer and they die? My sister didn't. What did she do to deserve to live? And I saw all those kids suffering, and I saw my family suffer, of course. I saw my sister suffer. And it was, I started wondering what is all this thing with suffering and what happens. And I started getting interested in, what's the mind and what goes on in, how does it function? What happens in my brain when I'm thinking about things and when I feel things, what happens exactly? How does that work? And then I was actually very lucky. When I finished high school, actually my dad could move to the US. Well, he moved to the US for his work. He was transferred there for a few years. And my parents gave me the opportunity to be able to study in an American university instead of going to a Belgian university. And I thought, oh yeah, I want to see something else because Belgium is a very small country, very complicated. And I wanted to, I think at that age, many young children, students then, they want to see the world. And then I thought, okay, let's try it, let's go for it. And so I, very last minute, applied for American universities, had no idea how the system worked there. And then ended up going to Brandeis, which was actually a university, which is a Jewish university. And so it was really, for me, when I went there, the world opened up. I met people from all over the place, from all different kinds of religions, and not Buddhist, but any other religion. I met people from and we became friends. And then I had the chance to major in neuroscience and take neuroscience classes. And that was really, I was like, oh my God, this is so interesting to try to understand how our mind functions. What is my mind exactly? What is my brain? What is consciousness? So I started reading books also, trying, written by scientists, of course, first, who were actually saying that the mind is actually our brain. There are actually quite some books that have been written about this, how, this materialistic view of ourselves. And even though I loved the studies, I really loved it. After 2 years, I realized, I did a little research with a professor also, and I realized I don't see myself going into research and spending, years studying one specific subject of neuroscience, even though I really love it. I want to do something more concrete. And so after 2 years, I took the very difficult decision to come back to Belgium to go to medical school, because obviously medical school in Belgium is nearly free if you compare it to the US. And because it's long studies, yeah, my parents would also say, well, if it's to study medicine, you better do it in Belgium. So I did come back to Belgium to go to medical school with this idea. After that, I'll do neurology or psychiatry, because I really want to continue to study the mind, and to try to understand how it works. Because and my idea was, if I can understand how it goes when someone is sick, when someone is suffering in his mind, has a mental illness, then maybe I will also understand how it goes when someone is not sick, how the normal mind works. Because if you understand illness, then maybe you understand, normal functioning of the mind. And so that's how I ended up back in Belgium in medical school. I must admit, I had my cultural shock coming back to Belgium instead of when I went to the US, because the world had been big in the US, and then suddenly I came back to something that I knew already, something very, how do you say, something that I knew, that and with people, I went to a Flemish university, the University of Louvain, Catholic University of Louvain. It's a very beautiful university. It's a very old university, but everyone there is Flemish, because it's all taught in Flemish. So I was back with only Flemish people, all people with a Catholic background, although people don't go to church anymore, but we were all from the same culture, basically. And so for me, this discovering of the world was, and it was quite hard when I came back. It was not easy for me for a while. But then when I started doing clinical rotations and working in hospitals, in all kinds of different specialties first, because as a student, you rotate in all different specialties, and then you make your decision what specialty you want to do in the last year. So back then, medicine was 7 years in Belgium, and I could start in the second year, because I was, all the courses I had in the US were the same than in the first year, so I could start in the second year. And so in the 7th year, I started doing rotations in psychiatry, and it was like, for me, when I started doing, even just being in a hospital, I was like, okay, I'm glad I did this, because this is what I want to do. I want to work with patients. I want to help them, and by helping them also understand the world better, by talking to people who are actually in a difficult part of their life, when they are, they are having health issues. And I actually I really liked other specialties too. I especially enjoyed surgical rotation, because there you have to be very quick and decide the adrenaline goes very high sometimes, and you have to be very concentrated. Yeah, and I liked family practice also. And but I decided to go for psychiatry, because the thing is, with psychiatry, we actually don't have technical tests. We don't have CT scans or X-rays. They can be sometimes useful to exclude certain pathologies, certain physical pathologies, but the main basis of mental health diagnosis is by talking to people. My main tool is dialoguing with people, and so creating contact with them. And so that's and so when I started doing my clinical rotation in psychiatry, I was like, okay, this is what I want to do. I don't want to do anything else. And so here I am. I still am. I ended up. So the residency is 5 extra years. So I did 5 years of residency, and then when I was about 30 years old, I became a psychiatrist, and I started to work in what I enjoy the most, is working with people who suffer from chronic psychotic problems or schizophrenia. I try not to use the word schizophrenia too much because it's very loaded, very stigmatizing for people. People are very afraid when they hear, oh, you work with schizophrenic patients. You are very, you must be very scared. It must be very dangerous, and it's not dangerous at all. I actually, yeah, I feel as safe as if I would do any other job. And so, yes, so I've been doing the job that I love for ever since, actually. And now, right now, I work in a very small hospital in Brussels, probably one of the smallest hospitals in Belgium, because we only have 30 beds. And I use the whole Belgian complication because I'm a bilingual myself. I'm one of the few exceptions in Belgium. Actually, in Belgium, you're either French speaking or Flemish speaking, and you don't really speak the other language very well. I speak both languages equally well. And that's actually, in the past, I would hide it. I would not dare to tell my Flemish friends that I spoke French at home. Now I tell everyone that I'm bilingual, and I use this Belgian complication. It's actually a very big advantage in Brussels, where I also speak English, because Brussels is a very international community. There are many nationalities in Brussels, sorry. And so I actually feel very happy there to be talking to people from all kinds of different cultures, all different languages, and yeah, who suffer from psychotic problems, and trying to help them the best that I can by dialoguing with them.
No, so fascinating. There's a few things I'd like to ask you about there, but before we go back, the Brussels Night Hospital is the hospital you're referring to. Right?
Yes. Yeah. Well, we call it Brussels Night Hospitals because there have been publications about our hospital, and in English we use that word. But if you look that up, you will not find the name and the address of the hospital because it has a Flemish name. It's called Psychosociaal Centrum Sint Alexius in Brussels, but it sounds better in English to say the Brussels Night Hospital because it's a night hospital. So people stay there for the night, and in the daytime, the idea is that even though it's called a hospital, the idea is to do psychosocial rehabilitation, so keep people as much as possible in the city, in the community, so to help them to find activities to do not separated from the rest. Like an asylum was in the past, they would build asylums, psychiatric asylums outside in the countryside, far from the communities, hidden from the communities. And actually we do the exact opposite in Brussels. We actually try to put our patients as much as possible in the community, with in the end finding a place to live where they feel good and safe, and that they will not lose it, because sometimes our patients lose their apartments or whatever. And so they get discharged when they have a place to go there and to go to and live. And then we continue to help them, even though they are not hospitalized anymore, but they are in the community. We continue, for many of them, we continue to give them some help in one way or another.
You mentioned there there have been papers referring to or written up about Brussels Night Hospital, as it's called, and yeah, so it's quite a well-known hospital internationally for being so small, and it's working there has afforded you a lot of very interesting and unique clinical experiences, which perhaps we'll return to. I had a couple of questions about what you said. This national complexity, the Brussels complication, Belgium complication that you mentioned there. You brought that up purely to explain your being bilingual. Is there more to say about that? Saying you'd inherited this cultural or national complexity in your childhood home. What are the implications of that?
Well, so yeah, actually, to be very honest, actually, and I have many friends who have. I have some friends who have similar background as I do. actually our ancestors on the Flemish side, even for me on the French side also, were from, in the past, from the Belgian elite. Belgium used to be one of the richest countries in the world at the turn of the 19th to 20th century. I think along with the UK, we were similarly, extremely rich because we had coal. We had lots of coal, and of course we had the colony of Belgian Congo. And so my ancestors were actually the ones who were having, who were in the big companies. I don't have ancestors who went to Congo, who colonized or whatever, but who were in the Industrial Revolution, yes. And so of course there was this Industrial Revolution in the 19th century. And my ancestors were part of that Industrial Revolution. So there is this, and so they would speak French because they were part of this elite, and schools were in French, universities were in French, even though they were on the Flemish part of the country. And so today, my generation has sort of inherited this thing of, we are not the elite anymore, which I think it's a good thing. But we still have those expectations from our education, to want to, these expectations of having to stay within the same type of people who have had the same type of education as we have, and so going to a school in Flemish where many people are not from this type of background. And so as a child, we could feel this pressure, those expectations, and the world was changing. And so how do you reconcile things you have received from your parents and your family in the world that is changing? It was not easy, and it still is something we don't really talk much about. So I still feel a little uncomfortable talking about this right now. But on the other hand, this is the reality, how things are, and it made who I am. And so I'm very sensitive to very complex situations, because when I hear, certain situations, the bad guys are this and the good guys there, reality is always very nuanced and very gray. And I think thanks to my my own the things that I've lived myself, it really helps me to nuance things and to understand that sometimes things are not as they seem. Things are not as black and white as they seem. There is a lot of gray, a lot of complexity in the world. And okay, I have my specific background, but I think many people have very complex and specific backgrounds, which can explain certain behaviors sometimes, which people would judge and say, oh, that's not good, that's being this or that. And actually, when you really understand, and that's maybe also why I really like the work that I do, is really try to understand why do people behave in a certain way and not another way. Because if you start digging and asking questions and really listening to what people say, then things start to make more sense in the way they behave.
Yeah, very, very interesting. Thank you. Yeah, I'd like to get into your clinical experience a little later, which you're being characteristically modest about, but I think that's perhaps clear, but we'll get into that. I don't know if this is a redundant question, but what do you think it was about psychiatry when you were doing your placements in medical school? What was it about psychiatry that really captured your imagination and captured your interest? You had an interest in neuroscience and the brain and etc., the mind and so on from before, but that doesn't necessarily track directly into working with actual patients in a psychiatric context. So what was it about those early exposures to psychiatry that so attracted you?
I think when I contrast how I decided not to go into neuroscience, even though I really loved the theory about it and reading articles and discussing and having courses about it, I had this idea that doing too much of that and going, because of course, if you start studying neuroscience, in the end, it's to go into research, do a PhD, postdoc, whatever, and really go into research. And I was a little bit afraid that it would become too much theoretical and not enough into reality, into how things are really going. And when I started, doing clinical rotations, of course, I didn't start with psychiatry. We start in general hospital. My first real rotation was with a GP. It was at a private family doctor, and I already really loved the way that the contact with people and their families. The doctor knows his patients for ages. He has seen them as kids and growing up as adults, and he knows the parents and the uncles, and he knows the whole family. And there is this whole relationship with patients. That dimension, that was something that I really wanted to go into. And so when I started my first psychiatry, my first day in psychiatry was actually in a ward in a psychiatric hospital, where there were many people suffering from psychosis, from psychotic problems, and actually seeing that those people, actually I really was touched by them. I still am actually. They have very strange experiences, which it's hard for me to relate to and hard for anyone to relate to. But they have this sort of, I don't know, I think it's very touching. And the problem is many of them have also lost contact with their families because their language that they use is so strange. That many of them are sort of rejected by their families, are rejected by society, and they actually, we shouldn't exclude them from society because they have in their own ways also very interesting things to bring into society, and it's actually, yeah, I think maybe in psychiatry, this way of trying to create contact with people, to create relationships, we are human beings and we are not separate entities. And maybe in the other medical specialties, we look too much at the problem, but we forget the human who is behind the problem. I have spent in my rotations in internal medicine, the doctors would spend days looking at X-rays, looking at blood samples, blood tests, and trying to find diagnosis and what's the best treatment. But then, we only have 5 minutes left to rapidly go and talk to the patient and tell him, you have this and this and this, and now you need to do this exam, and then hurry up to go to, and we didn't have time to speak with people, to talk to people. And I think it's in talking to people that you learn the most, I think. It helps the patients, but it helps me too. It's in both ways. I learn a lot from every patient contact that I have. And it's in the dialogue that I learn the most. Of course, technical tests are useful, but they should stay just the technical tests. And the main focus of our job should still be to talk to people and to talk to patients and to listen to them, because they have a lot to say that sometimes many times they don't dare to tell their doctors because they are afraid that, doctors will think they're crazy or something. And so lots of people withhold a lot of useful information to their doctors because of that. And in psychiatry, as we don't have any other way, we need to use this tool and try to make people talk and try to listen. We really need to listen and make them feel comfortable so they can really share what's going on and where they need help. And that's really what I love to do. It's really learning in the relationships we have with people, in the contact we have with people, and not just looking at tests or doing clinical studies where you haven't seen all those people who participate in the studies and you haven't talked to them and you don't really know, this whole standardization of things is something I have difficulty with. I prefer much more to listen to, because every experience is different, and that's so amazing, so wonderful. No one has exactly the same experience, and we all have different. There are so many ways we can live our lives, and so I think I'm in a very privileged position. That's why I really love my job.
Fascinating. And you mentioned before your interest in religion, and sparked there at an early age also. I wonder if we could follow that thread a little bit, understand that you've explored several different religious traditions, at least intellectually, and have quite some interest in Buddhism and meditation. And in fact, readers, if anyone's reading this, then really that's amazing, because we don't write this down. But anyway, listeners, viewers of this podcast will no doubt be familiar with Dr Nida Chenagtsang, who has been interviewed here 3 times. Remarkable Tibetan medical doctor, as well as a spiritual teacher, actually guru in the Tibetan Buddhist system. And of course, you met Nida Chenagtsang some years ago, and are now co-teaching with him. He recognized your clinical experience and of presumably the wealth of options he could have chosen from. He asked you to co-teach with him his counseling course. He's training counselors in the sort of mix or meeting of, actually not a mix, actually a meeting of Tibetan medical and religious ideas about the personality and about psychology and mental health and so on, with the Western medical model of psychiatry, which you bring. And this is very interesting, I think quite unique training going on, that's been going on for some time now, training counselors, and you're the lead of that. You're the leader of that program. Really remarkable, actually. So anyway, that's the end though. So could you follow that thread for us a little bit of your interest in that side of things?
How did I come to get into Buddhism, or how did I come to meet Dr. Nida? Or
well, I presume one follows the other.
Okay. So yes, so it started when, as an adolescent, I would go and get books from the library on Buddhism, and then it continued in my interest in neuroscience when I was at Brandeis, and then back then in Brandeis I wouldn't read much about Buddhism yet. I would read neuroscience books, and I would have discussions on religion with my friends about Judaism, about Islam mostly, and about, of course, the Christian religion. And we would have very interesting debates which would last the whole night, or, it was really, it was a very intellectually very stimulating time. And then at one point, I think it was right after I came back from the US, I found a book of Mathieu Ricard and his father. I don't know how it's translated in English. I'm sure it's translated in English. The Monk and the Philosopher would be the French title, Le Moine et le Philosophe. And Mathieu Ricard is this famous French Buddhist monk. And so in this book, he discusses with his father how he came to become a Buddhist monk. So his father is a famous French philosopher who is an atheist, who was an atheist because now he passed away. And so they went together in the Himalayas, and they had this whole dialogue that they recorded and then published it in a book. And that's what made Mathieu Ricard famous after this book was published. And of course, it talks a lot about Western philosophy, Western way of looking, and then the Buddhist way of looking. And to me, it was, when I read that book, I was like, oh my God, this is so interesting, because it's about the mind and how Western philosophy looks at this. And so they talk a lot about the Greek philosophers. and then Descartes and whatever. And then Mathieu Ricard explains the whole Buddhist, his whole idea of why he encountered Buddhism and became a Buddhist, even a Buddhist monk. And so I thought this book was really fascinating, and I started reading more about Buddhism after that, reading that book, and started reading all kinds of books. And it took, it stayed on an intellectual level for a long time for me. I like to feed my brain with intellectual stuff. So I would read a lot on Buddhism, but going to meditate, it didn't even occur to me to do that. I didn't even have the idea to do that. I also didn't know anyone who was Buddhist back then. And then a few years later, meanwhile, I was married and I already had 2 children, I think, maybe 3. No, 3 children. I had already my 3 children. So yeah, it's quite a while later. I had met some friends. I had made some friends who are still my very, very good friends. And their wife, she's actually from Tibetan origin. And thanks to them, I got to meet the first Tibetan guru ever. And he came to dinner to our house. And to me, it was, I was like, oh my God, the problem is that this Tibetan guru is from Tibet and doesn't speak any other language than Tibetan and Chinese. So our friends had to translate to be able to have the communication. But I felt like when I had met that person, I was like, oh my God, it's like I have met Jesus or something. It seems very crazy, but it's like I can. After we had met him, it was like, now I can understand why, sometimes in history there have been certain people like Jesus, where people would leave everything to follow him, because we could really feel this energy coming from this person in how he could, even though we had a big language barrier, how he could see and understand everything what was going on in the house. He didn't say much, but what he said was just to the point and very, and back then I had read books about Buddhism, but that's it. I had absolutely no experience and I started talking about my patients, and I told him, you say meditation should be something that everyone can do, but can you do that with people who suffer from psychotic problems, because I've read in papers that it shouldn't be done with people who suffer from psychotic problems. And then he actually told me, but you know what, you should learn to meditate. And then once you meditate, you just go and meditate with your patients. And then you see how it happens, because you will find a way to meditate with people with psychosis. You'll find a way that's good for them, because everyone can meditate, but we shouldn't do all types of meditation just like that. We should find a good way to meditate. And so that's how, the seed was planted to start to meditate. I've never seen him anymore because now he's back in Tibet.
Do you remember his name?
Yes, but I don't know if I can give his name for my friend's sake, for my friend's protection, because,
okay,
it's quite... I don't know, because I know when he came to Europe, he also had to come as a layperson. Otherwise, he wouldn't have been able to leave the country. And so I don't know if I can just say his name. Maybe if my friends give me the permission, I'll give you his name. But I know he's quite famous in China. But anyways, he was, it really, I was really, I still am very impressed when I think of him. And so now, so then I started, it took a while before I started to go to to go to a retreat, and I started going to retreats in France to another Tibetan guru, for which I won't say the name either. I learned a lot. I learned shamatha meditation basically with him, but then there were some problems. And so I ended up, there was problems with money and whatever. So I had my share of a little bit disappointments, and so I stopped going there. But I'm very grateful from what I learned there, because it really helped me to learn to start to meditate, to simple meditations, shamatha meditations. And then it's only later on that, actually just before the pandemic, that I went to a retreat organized by Dr. Nida, and in France, near Paris, and that's how I met Dr. Nida. And because I had a little bit of a negative experience before, I just went there thinking, we'll see. And then when I met Dr. Nida, I was like, oh my God, this is. I really got along with him, because I could really feel, even though he's not a Western doctor, he is a doctor. I could really feel that he really knows how to talk to patients, how to talk to people in general. You could really feel his clinical experience is really strong, even stronger than mine, I believe, because he really knows how to talk to people in a way that makes them really feel comfortable and really feel listened to. And I was really impressed, because even doctors around me, I don't have many colleagues who are that, who have that kind of, clinical. Actually, the first thing I was impressed with Dr. Nida was his doctor, his doctor identity, on how he relates to people. And I was like, oh my God, this is an example I should follow. I can become a better doctor by doing like Dr. Nida, by copying him. And then, of course, he started his retreat, and it was absolutely not about Sowa Rigpa. It was about eutocnintic things, and there also the way he talks about spirituality in a way as a doctor. Well, of course, for me as a doctor, this is just amazing, because he really makes this metaphor of the Buddha being the doctor, and actually, to me, of course, it speaks a lot. This language is the language that I'm very familiar with, because I'm a doctor myself, and I have patients, and I have medication. And so when he really relates that as a doctor's way of doing things, I was like, oh my God, this is really what I was looking for. And then the pandemic started. And so the next retreat that he was going to do in France was cancelled. But then instead he started this online Sowa Rigpa course. And then I thought, okay, I'm a psychiatrist. I already have everything I have. I have already a full practice, but I'm just going to follow the Sowa Rigpa course just to know more about it. And who knows, it might help certain of my patients who are very anti-Western medicine, anti-medication. Maybe if I can find ways with, more natural ways to help them, then that's going to help more people. So it's good to have, those different tools. And so that's how I got into this Sowa Rigpa online course. But really, before that, I had never heard of Sowa Rigpa before. And then as the course went along, I think we started to get to know each other a little better. And then he asked me to teach a few courses at the end of that first year. And then it went so well that we ended up, he ended up asking me to help him to create this counseling course where we include Sowa Rigpa and Western ways of looking at, of helping people, and also Buddhist ways, of course. And I think it's just been amazing up till now. Sometimes a little stressful, because I'm not used to be like that in the spotlights, but I see that it's really interesting, because it's everything that I love. It's all together. In the past, I would see all those things as separate, me being a doctor, me being the Buddhist philosophies, all those things were separate, and then now it's all coming together in. And I think it's really great. It's really wonderful.
Very interesting indeed. Yeah, gosh, there's so many things that I'd like to ask you about from this point. But perhaps one question about what you've said. You mentioned that there are certain things you saw in Dr. Nida that, as a clinician yourself, you respected a great deal and thought, this is. I recognize that skill set. Of course, in a slightly different context, but nonetheless, certain skills are the same. And indeed, there are even things that, in looking at him, you felt you could learn from through emulating. I'm curious what those were. If you could be more specific, perhaps, on what is the difference with clinical experience as, say, a doctor and the way one talks to somebody. That's your job, is talking to people and listening to people, a big part of your job. Can you say something about that skill set when one spends all one's day doing that? What does that give you? What are the markers of that skill set? And also, I'm curious, in Dr. Nida, and these are two perhaps rather different questions, what was it that you saw that you might like to emulate or you could also learn from?
Well, there is, first of all, the fact that he doesn't want to be put on a throne, and he wants to be, in the middle of people and be at the same level. And this idea, if I'm on a throne, then I'm alone up there, and I'm not. So people, there will be a barrier between me and the other people. And I think we should be careful for that in Western medicine, because as doctors, sometimes many doctors like to be, the doctor on, so that's why I don't really know if I should be called doctor or not, because for certain people it's useful. For other people, it scares them away a little bit, because then I'm too high above them, and that's not how I feel at all. And I don't think Dr. Nida doesn't feel above people either. So that's one thing. Another thing is the way that he would deal with what we call in Western psychiatry, we would call psychosomatic problems. There was this guy who was there at the retreat, who had some sort of problem, and someone came to ask Dr. Nida for help, and I went with him because we thought that he might have a physical problem, maybe a heart attack or something, and I could really very quickly see he had some sort of panic attack, and I think Dr. Nida also saw that. And the thing is that Western doctors would react, "Oh, don't worry, because it's not a heart attack. So don't worry, it will go away by itself." But if you say that to someone who is really not feeling well, it might just increase his feeling of unease. And so the way that Dr. Nida would be with that person, he would, take his time to really listen to him, to examine him, look at his tongue, feel his pulse, and then use a whole set of words that explained his feelings, saying, I don't remember exactly what he said, but it made sense for he talked about energies or whatever, and it made really sense for the guy. And just the fact that Dr. Nida was just really listening, and this guy really, his level of stress went down very quickly, and he could really relax anyways. And the few days after, every day, Dr. Nida would take a little time and go to that guy, asking him, "How are you doing today?" Even though he was well then, but just the fact that he didn't forget what had happened the day before, and he went to check on him and not forget about him. So this guy was like, "Oh, I'm important, this guru sees me, and he knows I'm there, and he's there listening to me." And so this guy was actually, I think he came back from, I don't know, but that he came back from that retreat being very, healed in a way, because, someone like Dr. Nida had been very attentive to him and be very nice and non-judging at all, actually. And so I thought, because of course we see many people who have what we would say psychosomatic problems, and they're usually thrown away as being, "Oh, it's just in your head, just forget about it." And And people are there, and then they feel frustrated because they do have really, they do have all kinds of symptoms and they don't feel well. And then the fact that they get, pushed aside as it's all in your head, don't worry about it, it makes this frustration even bigger. And I think that's also one of the reasons so many people are quite negative towards Western doctors, because they have had already those experiences before. And Dr. Nida takes everything seriously, what people tell him or symptoms that he sees, and in a very humane way, without being, the expert who will know better than the patient. And so I think that's really, and by being like this with people, how this in say has a healing effect on people, because they feel that they are there and they're looked at, and they are cared. Someone is caring about them. Is really caring about them.
I've heard you say that the quality of the relationship with the therapist, for example, or the psychiatrist or the counsellor, however we want to call it, is a really rather large part of the potential for recovery or healing.
Yeah. I believe it's actually the most important part. So we already know from studies in psychotherapy where they had been comparing psychoanalytic therapy with CBT and other kinds of therapies. And it's always the same. The results are always the same. There is no psychotherapy that is superior to another. And what really makes the difference is the quality of the relationship between the therapist and the patient. So it's that quality that will be the best prognostic factor. So the better the relationship you have with the therapist or the healer or the counselor, the more chance you will get better because of this therapy. So it's for me, it's one of the very important things is to invest in this relationship as a doctor, because yes, I'm a doctor, I'm a psychiatrist, I prescribe medication, but I know if it was just a robot distributing the exact medication that's needed, patients would not get as well than if there was, than if it was me with my relationship with them. That really makes the biggest difference for the patients. It's really, and you can see like that placebo studies say that a lot. It's really the quality of the relationship between the doctor and the patient that will have the most significant difference to help someone. I can see that also patients who don't trust me when I prescribe them medication will not work very well. And if they really do trust me, medication, of course, it's not always helping but it will help somehow. There will be somehow people will get better. And so that's also why I'm a very big fan of the attachment theory, because so the attachment theory, which really states that as human beings, we need to feel connected with other people in order to feel, to feel good. So it's not only about food and sexual reproduction, it's mostly about attachment, how human beings, relate to each other. It's really, really important. And so as a doctor, I really try to invest in this attachment, the secure attachment, as we would say in the West, where people feel safe, but where they feel cared for, where there is some unconditional, non-judgmental way of relating to them. And the more you can, you can invest in such a relationship, the better, the more healing effect it will have on the patient. So, yeah.
Yeah, you're mentioning attachment theory there, and it seems that continuing education is something that you've engaged in a lot in your career. You're also, from what I understand, family and systems therapist, which is itself a multi-year training. And you specialized, if I understand, during that process in attachment theory. Is that correct?
Well, yes, actually. I got trained in family therapy at the French University of Louvain, which is another university of Louvain. We have two universities of Louvain in Belgium because we are a complicated country. So, and I was trained by Edith Tillmans. She's retired now. She's very famous in the French world. I don't really think she's known in the English world. But she's an amazing, she was actually one of the pioneers of the family therapy in the Belgium, Swiss, maybe also French world. She also has a special background because she's actually Flemish. Her mother tongue is Flemish, but she became famous in the French world and much less in the Flemish world, which is quite funny. And so I had the chance to be trained by her in her last year before she would retire. And she's, she also has this very strong clinical experience with working with families. And when I met her, she told me, well, you should dig deeper into the attachment theory with working with families, because the attachment theory at that time, at least, was much more about, a child and his parents. And it stayed there about how a child relates to his parents or his primary caregivers. But she made me read books and dig into how we can apply all those things that we know about attachment theory, but in a clinical practice with working with patients and working with families. And so I'm very grateful to her about that, because it really made me think about how I was working as a doctor, because I was already, back then I was still a resident in psychiatry, but thanks to this background from family therapy, I could really invest into think about how to create secure attachments in my consultations, because I had never made the link of attachment theory, which I already knew about, but I had never thought of putting it in a clinical setting and try to use it and so that I would be then the primary caregiver of my patient, and the patient would be like if you make it a metaphor, I'm like the parent and the patient is like the child that I need to help and look after what his needs are, and the needs of that patient are not necessarily the needs of another patient. So really to be listening and trying to tune into what are the needs of that kind of person and not of that kind of person. And of course, when you also work with families, because sometimes I also see families, although I wish I would see more families than that. When we also work with families, how to make families feel safe enough. And usually when families come and see a doctor the first time, they don't know the doctor and they are quite paranoid, which is logical. I'm paranoid too when I don't know a doctor. I want to check is that going to be a good doctor? Is he going to treat my son well? Or is it some guy, and there are all those ideas about psychiatrists who seem a little crazy and so you can see when people come in, they are checking me out, which is normal. And so, putting words on that and saying, I understand that you want to know if I'm competent enough to help your son or daughter, especially that because I work with people who suffer from chronic psychotic problems, they already seen many doctors before me, and there have been many negative experiences. So why wouldn't it be a negative experience again? So trying to find ways to make them feel at ease and feel them safe, help them feel safe, because I know that's my first goal, is to help patients and family feel safe, because when they feel safe, the rest goes much more easy. I can help them much better than if they don't feel safe. Then I should put all my energy into that first. Because as long as they don't feel safe, then whatever I propose, they will not do it, or they will do it but not believing in it, and then stop it very quickly and not give a chance to the things I propose to help them. And so actually this will just block the whole thing if there is no trustful relationship with and it's especially complicated with people who suffer from psychosis because they're already paranoid. So they're already more paranoid than a regular person. So I even have to do more efforts to help them feel safe, because there is more paranoia to
Indeed. What have you learned about gaining that rapport, that trust? What are if you were to boil it down, perhaps it's not possible to boil it down, but I'm wondering if we could extract something of the essence of this focus you've had on creating this relationship, understanding it as you do, not only in the context of clinical studies showing the effectiveness or the importance of the rapport between the therapist and the patient, but also your understanding of attachment theory. And, well, you've described it. What could we extract the essence of what you've learned or your current thinking on how to achieve that? Someone walks in the door. What are we going to see you doing very often or not doing?
Well, now it's complicated because we have the pandemic, so I cannot shake hands to patients, which I think is a pity, because shaking hands is usually the first way of the way I shake hands, in a sort of convinced way, but not forceful way. Those are it's small details. So not some sometimes people shake hands. It's a very weak hand. So I don't have that weak hand, but I also, some people, they squeeze so much that it nearly hurts. So I don't do that either. It's somewhere in between, but where I show that I feel confident when I shake hands. And when I shake hands and then I feel how the hands of the other person is, and I can feel how confident the person is. If it's it gives me, and also looking at how the person looks like, is that person, the way that person dresses, gives me a lot of information, all the nonverbal things around someone, and the way, also the tone of his voice, the way he says hello or whatever. And then they come into the room, I make them sit down, and then I will usually, to make people, at ease, I will try to say something about, the weather, for example. I don't know, maybe in the UK it's the same as in Belgium, but that's like the national thing, is we complain about the weather. So there's always a way to complain about the weather. And even if the weather is nice, sometimes then we say, oh, finally we have a nice day today, so we should enjoy it. And so, or say something about the football, because of course that's the national, if I can see it's someone who probably loves the football, I say, oh yeah, we won yesterday, or try to find small things that I can see what kind of interest does that person have. Maybe for football, I will not say that to an older lady who doesn't really look like into football. I will not say anything about football, and if I really don't know what to say, then I will say something about the weather, about the traffic jams, but something, and try to make some little joke or something. That's also something Dr. Nida is really good at, is to tell jokes to make people feel at ease. I don't have his humor, but still I try to, to say something small and funny, and that they can relate to. That doctor is not that weird. She's not that such a weird psychiatrist. She also, complains about the traffic jams in Brussels, or the noise, or whatever. And so I try to, and so that's also always a very important, is to try really the first minutes to have someone already feel, okay, we can be normal here. We don't need to be complicated. We don't. And then, of course, I have patients who have all kinds of interests. I have a patient, every time he comes to see me, he talks about the news. So I know I need to know stuff about the news, because then he will start, and this and that. And then he talks about, and then I say, oh, yeah, that's true. And the Russians and the pandemic and this. And then I relate to him, because he's so interested about the news. And then once he hears that I know about the news too, and that I say, oh, yes, that's true. It's really not fun that now we have to stay inside again with the COVID and whatever. And then once all that has been discussed, it's always some sort of ritual. Then he starts to talk about his own complaints, because he's like, okay, the doctor knows the same thing about me, about the news. So now I can start talking about my personal issues, and then we can start talking about his personal issues. Because when you try to relate to people's life, interests and things like that, then it's going to help them, to make them feel at ease, and start discussing what's going on with them, and how they feel actually.
That's very interesting indeed. I'm wondering about that ritual. Perhaps less experienced clinicians might worry that one's wasting valuable consultation time in small talk. But you are recognizing the value of investing in that so that what follows is so much more efficacious. That makes sense. Do you ever encounter a situation where a patient will attempt to camp out in that sort of small talk to avoid addressing the issue, for example? Do you find yourself having to circumvent that in any way? I'm curious about that. So what would you say to the clinician who says, well, I don't want to get too bogged down in small talk. What if we never get to the main problem? And do you actually encounter a situation where you have to redirect the flow of conversation to the issues at hand?
Yes, actually, well, I think it's always good to have small talk. And of course, and then it depends on the patient. If you start to realize that he's trying to avoid the main subject, then at one point, I just ask, so what are you here for today? Or how are you doing today? How are you doing? And then he will maybe talk about something else. I say, okay, yeah, that's also very good. You already told me that, but now I really want to know how you are doing, because I'm your doctor and I want to know how you are doing. But I think this preparation of the small talk ritual is good to help people feel at ease. And then for some people who are very, who are stable, because of course I follow my patients for years. So it's not the same as when you're doing a real psychotherapy for, I don't know, a few sessions, a few months, and then that's it. It's going to be different. But for me, I follow my patients for years, whether they do well or not, they continue to come and see me and consult me. And so when they're doing well, then there is a lot of small talk. Because why would I talk about problems if he's doing fine? It's going to make him, the sick patient again. And I think sometimes talking about other things really makes him not always have this label of the patient who is sick and not normal. And actually, in the beginning, I felt uncomfortable with that too. I was like, oh my God, I've studied for so many years, and now I'm talking about recipes of, bechamel sauce. I've had that once with my patient who asked me, doctor, please help me. I don't know how to make bechamel sauce. So I looked up on the internet and I found a very easy recipe for him, wrote it down on a paper, and he was asking me questions, and that was the consultation. And he was so happy, he didn't need anything else. So I'm not going to then say, because I felt that he was doing well otherwise on a mental level. So I wasn't going to ask him other things than that. And then so we're just talking about, actually I talk about food a lot, because I have patients with food, with health issues because they eat too much and in an unhealthy way. So, and then I'm a psychiatrist and I'm talking about food with my patients. But then what the hell, if that's what they need to talk about, then they are the ones who decide. But if I really feel it's a problem because they are not going to talk about their problems and there is a problem, then I will, I will dive into the question and just, straightforwardly asking, okay, what's going on with you and how are you doing right now?
That's very interesting. You've talked there about how to establish that rapport in the opening moments of a consultation. And also you're talking about how that rapport looks on an ongoing basis. I'm curious, what, if this might be an incorrectly framed question, but I'm curious, what are easy ways to lose the trust as the relationship progresses? Are there easy or common mistakes that you think can be made that can result in losing the trust? Or are there key moments or key pivot points in a therapeutic relationship where it's make or break in terms of the trust, that perhaps would be a place a clinician might put a foot wrong?
Well, to me, it's very simple. It's not telling the truth or hiding the truth or minimizing the truth. Because even if, the patient doesn't want to hear that, even doesn't like to hear the truth, at least when you tell the truth or how you see things, because maybe I can be wrong sometimes, but say how I see things in an honest way. I'm never going to lie to my patients. And I see that they really appreciate that. Even sometimes they get annoyed at me because I've said things they didn't want to hear. they know that at least she's being honest to me. So if I say other things that they wanted to hear, they know that I mean it. So I'm never going to say something I don't mean to someone. And so, and I think, but that's in life also, if we realize someone hasn't been telling us really the truth or has been hiding stuff to us, we will not trust that person anymore either, right? Even though afterwards they'll say, yeah, but I did that to protect you or whatever, we don't like it. We want to, you know, it's important to, you know, to remain authentic and just to say how we feel. And of course, I have those kind of discussions a lot with people who have, who, for example, smoke cannabis. Cannabis, in regular media, you hear all the positive things about it. But in my clinical practice, I only see problems with cannabis because cannabis is a high risk factor for psychosis. And my patients, well, most of them smoke cannabis, especially the younger ones. The older ones, not so much, but the younger ones, all of them do. And so when I tell them, well, cannabis is not healthy for you, and the best way, you know, to help yourself is to stop smoking pot, then they, you know, many of them don't like to hear that. And they say, yeah, but then, and then they try to find all kinds of arguments why it's good anyways, because in the media it is said it's medicinal and this and that. And then I keep saying, well, it might be for some people that it's good, but not for you. And so if your friends don't have problems, well, yeah, they are not sitting here with me, you know, they are not here in my consultation, they don't have psychosis, but you do have psychosis. So if your friends are really good friends, they should know that and should help you and maybe stop smoking when you are there, when you are around, because in a friendship, we're supposed to help each other. And if they know, it's like if you have an alcoholic friend, you're not going to start drinking in front of that person if you know he has a hard time get away from the alcohol. So you find another way to help because he's your friend and you don't want him to drink again. And so same thing for cannabis. And so I have a lot of discussions like that. And I have had patients who got very angry at me. They stood up and they say, I'm going to change. I'm going to another doctor. I don't want to speak you into anymore. You are really a bad, old-fashioned, traditional doctor. And then they slam with the door and they leave. And then 2 weeks later, they come back. And then they say, okay, you might have been right, you know, because I have had this and that problem. And then they start to, and then I tell them, you know, instead of saying, okay, let's just stop cannabis right now, just try for a week or 2 weeks without cannabis and see what happens and see how your symptoms go. And then you find out by yourself. And so, and then by being always honest and not trying to be popular, because that's also, you know, I think many young people who start, young clinicians, they will try to not be unpopular. And I have learned that that doesn't help. I'm like, okay, if you don't like me, if I'm not popular, then that's it. Right? I cannot change who I am. And to dare to be unpopular. And that's one of the good things about the training in family therapy is that you learn to be unpopular. I mean, you learn to dare to be unpopular and not to please the other person. My job is not to please the other person. My job is to try to help that person with his problems that he's encountering right now. And so and for someone young who's starting, who doesn't have much experience yet, it's difficult because you want to please your patients. You want them to like you, and you know, getting out of this, I want them to like me. It's more, I want them to know that what I want is, I want them to feel fine. And it's like also parents with children. We shouldn't be popular parents. We should be good parents for our children. So if my child tells me, oh, that's not nice for later, I want to, you know, some adolescent who wants to go party, and I tell him you have to be home at midnight. And he says, well, I want to come back whenever I want to. And if it's 3 a.m., then I want to be back at 3 a.m. Well, it doesn't make me popular to say you come back at 12 because I'm your mother. Yeah, but that's not nice. And why is that? And all my other friends can come back at 3. And I say, I don't care about your other friends and their other parents who let you go out for a longer time. I want you to be back at 12. and that's it. Well, then I don't like you anymore. Then I say, okay, then you don't like me anymore. And then, but at the end, they respect you much more because they feel that you said those, you say all those things because you care about them, and there are certain risks associated with certain things, and so you don't want those risks to happen, and you want to protect them. And so on the short term, they might get very angry, but on the long term, you get more respect, and they will listen to you much more because it comes from you, and they know. And the day that you tell them, okay, you can go back at 3 a.m., then they know that you trust them well enough to do that, and they will do everything to make it, So I think, and that's a confusion I think we also have in general society. Many parents, they want to be, they don't want to have too much trouble with their children, and so they're trying to be the friend but I think it's not possible, because the parent is above and the child is underneath, and we need to protect our child. And whereas friends, it's not our job to be, well, of course, we'll try to help each other out, but it's not the same relationship with a friend because we're on the same level. But a parent and a child, or a doctor and a patient, it's an asymmetrical relationship, or a guru with a student. You have many asymmetrical, or a boss with someone. So we have in society, we have many asymmetrical relationship, and then you have symmetrical relationship where you have people on the same level. And we should really, depending on the type of relationship, it has its advantages. It's important to, you have a that's why we say doctors have a responsibility. Our responsibility is to help and protect our patients. And so sometimes we need to say things that they're not going to like to hear.
Yeah, very fascinating. That asymmetry, those asymmetries that you're pointing to, of course, have a function. They're functional. And presumably being the friend of one's child and denying that asymmetrical dynamic forces the child, in a sense, to take care of themselves in a way, or create their own boundaries and self-regulation at perhaps a premature time. Eventually, presumably, that asymmetry gives way as the child grows, matures, and internalizes the role you're playing, and is able to set their own boundaries and regulate them themselves. They don't need the parent to do that anymore. But that's something that presumably they learn to do that through relating to the parent, actually outsourcing that role, you could say, temporarily in their development. Is that fair to say?
Well, their children are always going to try to follow some sort of example to follow. So it's either the parents or it's going to be the peers if the parents don't do it. And so then there's role models become the peers, but the peers, they don't have the maturity of the parents. They don't have the life experience of the parents. So you take more risks. Then it can turn out fine, but it can also become problematic if you choose your peers who, depending on the type of friends that you choose, if they go and do dangerous things and you see them as role models, well, you'll do those things too. So I think it's really important that up to a certain age, parents remain the role models, the primary role models, the primary attachment figures. But then there is this trustful relationship that builds up, and then you trust your child more and more, and you give him more and more responsibilities. And then at one point, he doesn't need you anymore because he knows himself what he can do and where the dangers are. And because certain parents also do the opposite. They don't give any freedom to their children. And then suddenly at 18 or 20 or whatever, they arrive in the adults world and they have never received any responsibility. And then you can have the complete opposite reaction, and they go do all kinds of crazy things because they have been held too much, too strongly, too strictly. So I think it's very complicated as a parent. First, you need to protect your child because he depends completely on you. But then over time, you give him more and more responsibilities and more autonomy and more freedom. And this pace is different from one child to another. Certain children attain maturity much faster than others. And so how do you, and that's this whole thing of attuning, is as a parent really looking at what does that child need right now? Do I still need to protect him for that or not? Can I already trust him for that? And if you give that trust at one point, before even the child asks for it, you say, okay, I understand, I give you that trust, you can do that. Then the child feels very proud that you trust him to do that. And so he will, want to show you that he deserves this and really do the things as well as he can. So I think it's also important as parents to give freedom to our children, that, and one child is not another. So, and then it's complicated when you have different children and their siblings, and they have different personalities, and then the children say it's unfair, you can do that and I cannot do that yet, and at that age this and that, and so and then it's always trying to find a way because of course children are also patients also, they are very sensitive to the doctor being fair or not fair, especially in the hospital where they are in a community. When I make a decision and I say this patient, sometimes I have to exclude patients from the hospital. For example, if someone has been dealing drugs in the hospital, then I say, sorry, now you leave. Yeah, but I don't have a house. Well, that's too bad. You knew you cannot deal drugs. And of course, I cannot tell that to other patients that they have been dealing drugs. And other patients hear that I excluded the patient who has no house and he's now homeless. And then they say, it's unfair. Why did you do that? And, there is this whole, and then you cannot say everything because you have medical secrecy. And so this whole thing about when are things fair or not fair, or everybody's equal, we are not always equal, because we all have such different stories. And how do you balance all those things? It's not always easy.
When you talk like this and introduce all these different dynamics, it does make me reflect on the importance of a certain, or at least the relevance of the therapist's own psychology and issues. Of course, we've known for some time, popular in consciousness, I think, this idea of transference and counter-transference. And it is possible, of course, for a therapist to be drawn into a kind of, should we say, unhealthy dynamic from both sides. The therapist can also be drawn into that dynamic and begin to buy into that dynamic and participate in a sort of psychodrama intentionally with the patient, moved off, if you want, their center. And I expect that all the things you're saying, this tolerance for being unpopular, this navigating freedom versus boundary function, or care and compassion, these dynamics seem quite difficult to navigate. And perhaps a vulnerability is the therapist's own psychology, their own psychological background, perhaps previous woundings or patternings that they may have encountered in themselves. I think that's something also that comes up in attachment theories, as you point out. The therapist is involved here. The therapist is an active player in an active relationship here. So I'm curious, and then I would like to ask you about hyper-religiosity. I'd like to ask you a couple of questions about that. I know we've been talking for quite some time. How do you stay, I suppose, for want of a better word, centered? How do you keep your center amidst the tidal forces of not only your patient's psychology, but also your own psychology?
Okay, so then I think, it's a very good question. I think, first of all, is to understand my own difficulties that I have had in my life, that I understand dynamics that I had. That's why they also say, they encourage, if you are learning to become a psychotherapist, to also go into therapy yourself, to understand your own personal dynamics. I know I'm sensitive to certain things, and thanks to having been through all this self-reflection about myself and in this dynamic. And that's also why I said in the beginning, many things from our lives we have learned, we have received from others. I think a child is born, as they say in Buddhism, we're born with bliss. I think it's really true. A baby is born with bliss. Well, maybe during the pregnancy there is bliss, and it can already change during pregnancy if there is already a lot of stress around. But let's say at one point or another, a baby in the beginning is full of bliss, but then we start to inherit all the projections of our environment, all the emotions in children and babies absorb all those emotions and they internalize them, right? We are like sponges and we internalize, and then we start to believe it comes from us. But we actually inherited it from our parents and our families, who they inherited it from their parents. And then you can go like that back for generations. And then, so for example, when we talk about trauma and then we start to blame, oh, my parents, this and that, for many patients, it's complicated because they don't want to blame their parents because they love their parents, but they have been traumatized by their parents. And so it helps to say, well, my parents were actually victims of trauma by their parents, who themselves were victims. You know, it's certain sort of generation. So we stop blaming our parents because that's how they functioned. They didn't know how to do otherwise, and they had inherited it from previous generations. And so then it's okay, I still love my parents, even though they have hurt me and they have done, you know, things that should have been better otherwise. But then how can I change things and understand those things so that I don't transmit them to my children anymore? And so I think that's the real healing, right? It's to be able to understand. So so when we talk about transference and countertransference, I've had situations where the countertransference was really high for me. And then, you know, you see someone and you get really angry at that person. And you get really, you know, you want to throw him out of the window. And then it's like, well, are those emotions really mine? You know, are those my emotions? Do I really? And then actually starting to think, well, actually, it's that person who made me feel that way. And then accepting that, okay, it's not my emotions. I just sensed those emotions and I sensed them so strongly that I ended up believing it's mine. And so by realizing it's not our emotions that we capture when we are in those countertransference or transference situations, really helps to take some distance from it, and then to look at the bigger picture. Okay, why do I feel this anger right now? So that probably tells me about that other patient who probably carries a lot of anger inside of him and cannot express it. And he finds another way of expressing it by making me express that anger. But the anger is inside of him. And so I think that's why, yeah, learning to understand, because if I'm already someone who gets angry very easily, it's very different than it might be my anger, you know? But if I know that I don't get angry very easily, then, and so that's why to do this psychotherapy on ourselves is really helpful to really understand where all our personal dynamics come from, and also where do we lose confidence, and it's also, you know, usually related to certain things we have lived through in the past. And so to know that and then use those things actively. For example, this popularity thing, to give you an example, I'm the oldest one of 4 children. And usually that's also what I learned in psychotherapy. In a family with different children, the eldest ones are not always the most popular ones amongst the siblings. I was definitely not the most popular of our 4. I get along with my brothers and sisters quite well, but if there is someone to blame in the 4 of us, it's always going to be me, because I'm the oldest one, and so I'm the most unpopular one, because all kinds of reasons. So I know that whatever I do, there is always a risk of me being unpopular. And so instead of trying to fight against it and trying to be popular, just assuming, for me, when I'm with my patients, assuming, okay, I'm unpopular, I'm used to it. I was unpopular when I was a child, you know? And so using those parts of us when we are working with other people. So it's very useful to understand certain dynamics we've had inside our families, so that we can use them when we're working with patients. And for example, someone who is the youngest of a family, the youngest usually receives more freedom than his older brothers and sisters, and he will try out more things and be more creative. So if that person becomes a therapist, he can use that creativity and that, you know, so that he's going to have a very different style than someone like me, who is the oldest one and So we will try to use those parts of us as strengths in order to find ways to help our patients. And it's different for everyone, because everyone has a different story, has a different history, and so. But I don't know if that was answering your question, because I don't remember your question anymore.
Well, it was about how to stay centered, yeah.
And how to stay centered. So yes, if we know that, and so that's one thing. And then the other thing for me personally is I can really see how meditation, although I feel I should do it more, because every time I do it, it helps me stay grounded and centered when I see patients. And so what I do is, when I know I'm going to have a difficult consultation with a patient, where there's going to be very difficult subjects that are going to be, discussed or something, I do a short meditation where I try to just stay grounded and just for a few moments, a few minutes. And this really helps me to stay really focused when the person comes in, and really, helps also to concentrate and not be distracted, because when I'm distracted by other things, the consultation doesn't have the same power, actually.
It's so fascinating, and I think you're pointing there to metacognitive awareness, an ability to monitor one's own mental and emotional state, or have at least a toe out of that water. It's very interesting indeed, and pointing there also to meditation as a means of reinforcing that metacognitive awareness. Yeah, that's fascinating. While you're here, Dr. Caroline, I can't not ask about this. With your particular experience. So, religious experience. We know, I think, that religious experience is presented in a very broad way, even in the, say, psychological literature of the last 100 years or more. Freud talking about it as patently infantile. I have a quote here actually from his 1937 essay: "Religion comprises a system of wishful illusions, together with a disavowal of reality, such as we find in an isolated form nowhere else but amentia, in a state of blissful hallucinatory confusion." And that's, of course, in the 30s, but even as late as 2004, Ryan McKay, in writing in Evolution and Cognition, his article "Hallucinating God: The Cognitive Neuropsychiatry of Religious Belief and Experience," echoes, I think, something of that. This is from his extract. "The claim that religious belief is delusional is evaluated using a current cognitive neuropsychiatric model of delusion formation and maintenance. This model explains delusions in terms of the conjunction of two cognitive deficits. The first, a neuropsychological deficit, giving rise to an anomalous perceptual experience. The second, a deficit in the machinery of belief evaluation." Very fascinating, actually, that paper, pointing to religious belief as a sort of attempt to somehow, perhaps even quite a logical attempt, to integrate some anomalous experience. And he points to the example of the difference between cognitive recognition and affective recognition in certain patients. This person looks like my wife, but I don't feel that sense of recognition. So therefore, this isn't my wife, this is someone pretending to be my wife. It's, in a sense, a logical conclusion to be drawn from an anomalous experience. And so the point, or the suggestion is made, that perhaps quite a lot of religious belief, especially that coming from religious experience or anomalous mystical experience, could be seen in this sort of dysfunctional way. I'm wondering what you think about that. But also there have been claims made that religion can be very helpful as a sort of coping mechanism, and that religious belief can provide a certain level of meaning, particularly in clinical situations, that can be very helpful. I'm thinking, for example, of it's often said that religious conversion is one of the most effective means of addiction recovery. If someone can have a complete, not only psychological, but also perhaps crucially social change, that this identity and social change can be quite effective in addiction recovery, an area, of course, which is notoriously poor. So I suppose, you're dealing with people with psychosis, chronic psychosis. I'm sure you see your fair share of religious themes coming up there, both both positive and negative. I wonder if you might reflect on the range of religious themes that you see, presumably positive and negative, coming up in your practice. Maybe I'll follow up with some more questions later.
This is a very long question. I think I could take hours to answer that. But maybe first to make the difference between someone being just benignly religious or spiritual or whatever. There's a difference between that or someone having mystical delusions. By having someone who has mystical delusions, I can give you an example. I have certain patients, now I'm thinking of one of them, who claims he's an atheist. He says he doesn't believe in anything, but in his delusions, in his hallucinations, he talks to God. So he hears the voice of God talking to him and giving him orders and telling me to do this and he shouldn't do that. And he sort of knows that's part of his problem. And so he comes to me and tells me, God has told me that now, and should I do that? Should I not do that? So for example, at one point, he won't dare to take a shower anymore because God told him that if he takes a shower, he'll have all kinds of different problems. So he starts to stink. So then I try to convince him to find ways how to disobey God and take a shower. But this guy, if you ask him, what are your religious beliefs? He says, I'm an atheist. So it's quite paradoxical, it's not always because you are religious that you don't have, that you have mystical delusion and hallucinations, and the other way around. It's not true. But I do have quite some patients who talk to God, hear God, or are chased by the devil, or they hear voices of the devil trying to annoy them, and so the subject of religion is very, it's very much there. But then there's also people who have very strong beliefs, like, okay, I have all those symptoms, but then I'm a very religious person, and when I go to church and when I pray, then I feel protected and I feel better. So then the religion is not part of their delusional problems, but it's actually helping them cope with all those difficulties they encounter in life. And so that's one thing. And again, then who are we to say that religion is a problem? I think for many people, it is really helpful. For some of them, might be problematic, especially if they are being raised in some very dogmatic beliefs. I've patients who come from very Christian backgrounds, and then they feel they are homosexual, and it's not accepted in their Christian way of looking at things. And so they have developed all these delusions and hallucinations around this theme of homosexuality because they feel guilty. And so, but then on the other hand, that's how they are. And should they feel guilty or not? Should they be angry at their family? And in the sort of psychosis is kind of coping mechanisms with all their internal struggles they are having. It's a way of coping with that. And then what I also want to say is this whole thing about what's a delusion. In fact, when patients come to me and they say, "Doctor, am I normal?" That's a question I hear a lot. Am I normal? And then, my answer is, what is normal? What's the function of our brain? Why do we have a brain? What's one of the most important functions of our brain? And then people they don't know what to answer to that. And then I say, well, the brain's function is to interpret reality, is to make sense of what's happening. And actually, we don't see reality as it is. We see a distorted view of reality. And that joins the Buddhist philosophy very much, because that's also what they claim is we're actually hallucinating. We see a distorted version of reality. And so for very simple, we see colors. There are no colors out there. It's our brains who create this color function for us. Outside, it's just wavelengths. In our eyes, they don't see colors. They capture the wavelengths, sends this information to our occipital lobe, and there we interpret in certain pathologies of the eyes or of the brain, make that people become colorblind. But is their reality wrong and our reality is right? I don't think. It's just another way of looking at reality. I don't think that someone who is not colorblind sees things as they are, and someone who is colorblind sees something that's completely wrong. And so that's just about our senses, but everything we also anticipate. So we will see things that we expect seeing, and things that we don't expect see, we will shut out. And so when there is an event happening, and there are many people there, and then you ask everyone to talk about what has just happened, everybody will have different memories about what happened, because we remember what's important for us. And that also depends on our background and what we have been going through. So actually, no one sees reality as it is. We see as so our brain interprets it, and it's good, because if we didn't have that brain to do that, we would just be in a big chaos. So it's important, it's not that we should stop hallucinating, or being delusional. It's good to be delusional, but it's important to recognize that we're being delusional and hallucinating, and we see things and all this story about false memories and everything, and people deniably believe about certain things, but it's because our brains continuously construct a reality for us. But of course, there is an influence of the outside world, but we don't see the things as they are. And so when I tell my patients, well, what is reality? Because if someone hears voices and I don't hear them, who am I to say those voices are not real? Because for that person, those voices are very real. And so my job is not to make everybody stop being delusional or hallucinating. My job is to make what they are going through livable, and that they dare to come out, and they dare to have social interactions with other people. Because that's the problem. The guy who doesn't dare to take a shower because God tells him not to take a shower, he'll get into trouble because he's going to start to smell bad. So actually the problem is that it's not really the fact that he hears the voice of God. If God tells him nice things, what's the problem? And so and so for me, it's really what are the effects of what we are going through on our functioning in daily life. And my job is to help people being able to function in society, to find a place where they feel well, they feel fine, and where they have significant relationship with others, because that's what's important for us as humans. It's very hard to be isolated. So, but then religious experiences, I see that. And it's actually said, as you say, for people with addiction problems, the fact that they start to having religious convictions and everything helps in recovery. That is true. That is why, for example, the AA works for certain people, and for certain people it doesn't work because they don't have those religious. Among other things, some people also have difficulties with group therapy, and so that's also why they don't go to the AA, or they don't feel comfortable in the AA. But people who have some sincere religious convictions, which is very authentic and not because it's part of their culture. That's what I mean with sincere, because if it's part of the culture, then it becomes a cultural identity, but it's not something very deeply rooted inside. But someone with a very sincere religious experience or whatever, those people tend to have, a more positive prognosis. I believe I see. I see that it's helpful. Actually, it's not actually something. It's not an obstacle. I also see I have started now, I think it's been 4 years ago, to do some small meditations with my patients. Took me many years after that first guru told me you should learn to meditate and then meditate with your patients. So I started doing that, and I do very short meditations once every 4 weeks or something, 5 weeks, with patients who are interested. And I can really see that in the beginning, I didn't dare to do that because I thought I'm a doctor. I'm not a chaplain. It's not my job to talk about religion, but patients were talking about it by themselves. They were talking about religion, about spiritual experiences. And so at one point, I just decided to let them talk about whatever they felt like, and then, answering to what they were asking and asking questions myself. And so now every time we talk about religious experiences, and I can see how helpful it is for them. And they have all kinds of different religions, or even one of them is even non-religious. But I can see he listens to the others, and and no one is imposing his view on anyone because everyone has a different background. And so it's really talking about personal experiences, and I can really see how helpful it is for patients. So I wouldn't say that religion is something bad or something delusional or whatever, because in that case, it's actually very helpful for people. And maybe we have been separating religion too much from the rest, and as a human, we need to integrate everything together instead of separating everything.
That's very interesting. I think one doesn't expect to hear a psychiatrist say that if you're having delusions is not necessarily a bad thing, and that in fact you're going further than that and saying that on a certain level, due to the top-down contribution that we make to our experience of reality, we're all participating on some level in constructed reality of some sort. And if you want, delusion, functional, maybe the functionality of that delusion varies, and that's perhaps why some people will end up in your treatment room. Mm-hmm. That's very surprising. One expects a psychiatrist to say, "Oh, you're hearing voices," and then on goes the straitjacket. Maybe that's an old-fashioned idea.
Yeah.
But let me ask you this. We may have to do a sequel and go into this in some more depth, Dr. Caroline, because this is so fascinating. But where do you think this attempt to frame religion and religious experience as a pathology comes from in the psychological literature? Where do you think this, I don't know if I could say anti-religious, or at least framing religion as pathology, comes from, and what are its implications?
Well, for me, I believe it's something very from the West, right? When Descartes started talking about dualism between, the mind, which is immaterial, and then everything else, which is material, and how science started to study the material world. And so that's, I think, one thing. And then the other thing is this separation of church and state, which happened in a lot of countries in Europe, where there is very much this separation of both things. So how people can believe whatever they want, but that's in the private sphere, and then the other things, so science and technology and everything, we can do all those advancements without having religion. So maybe religion is old-fashioned, and it's the Ancien Régime before the French Revolution, and the clergy, and there were probably, there were definitely abuses from the church on the people in the past, and religion trying to dominate populations. But I think religion also has some good things, because I think we are all inherently, we need to have some connection with something higher and bigger. And I don't know if what this connection is placebo effect or not. I have no idea. But meanwhile, I think it's important. And I think today we live in a world where that's the criticism on the scientism, that this highly materialistic way of looking at things is that, and that's also what we see in psychiatry, is that people suffer because they are sick, and because they are sick, they are not useful for society anymore. And so they become put aside from society because they are not useful. They don't bring money in the thing. Or older people, we put them into elderly homes and we wait for them to die. Well, that's a very crude way to say things, but that's what actually kind of happens. people who are sick and old are not useful, and so psychiatric patients with psychotic problems, of course, they are not useful because they cannot. There are very few of them who have paid jobs, at least the chronic ones, and so they cost money for society. And so in certain countries, they are even the homeless people who live on the streets because society is not even taking care of them. And so I think we have, and so there's this sense, and this sense of loneliness, you know, we don't have much connection anymore. We should have a good job, high paid job, and be useful in society. And that's what I hear a lot from my patients is, I'm a burden for society and I shouldn't be here, because actually they feel guilty for, you know, for being such a burden on society, and they receive money from the state to just live. And actually they are in the way because it's complicated. If there's something happens, they will be a burden for their families. It will be a burden for their friends, and so they will have no friends anymore. And so this idea, but this worldview that you need to have a job and that's what gives meaning to your life, and have money and be important, and everyone who doesn't fit into that plate is, you know, is actually too much, or so, that's the extreme view of things. And I think it makes people suffer, because that means you need to be someone important to be important, and actually just who I am is not enough. And maybe in religion gives more meaning to life than just, you know, having to bring money in society and be useful for society. The religion, you know, they ask questions that go much farther than just, you know, being someone useful in a materialistic society, and the day we die, then we disappear. You know, that's kind of this material. And for many people, that's a very big source of suffering, actually. I think that's materialistic worldview is a much bigger source of suffering than people who are authentically religious and who authentically believe in certain things.
I wonder if that's the case. I wonder if there perhaps the sort of materialistic or scientism, as it's sometimes put, this sort of science, in a sense, an overreach of science is sometimes how scientism is framed, is committing actually a religious mistake, which is, for example, I think perhaps some of the motivation behind an attempt to debunk religion, or at least disrupt it, may come from an observation of the sorts of suffering that religion can cause. Strongly held religious belief and conviction, for instance, of course, many people have suffered at the hands of religiously justified actions of various kinds, or actions carried out by religious figures or religious authorities on a small scale and a large scale. And I think a natural response to that would be to say, well, on what basis is this assertion being made? On what basis is this authority being wielded? On the basis of religion. And then we examine, well, what value does religion have as a truth claim if it can produce this kind of a consequence? And so then naturally one might say, well, what's a better basis of truth claim or authority? Well, perhaps science, scientific method, experimentation and evidence, etc. And I think it's an understandable, and perhaps in many cases, we think of just simply the history of medical science and the advances that have come from using evidence to open up different possibilities. But the problem seems to be that, as you point out, at least at this point, scientific method and so on can't give us all the knowledge that we need. This need to be in part of some story. This need to be have some place in some sort of cultural narrative, and perhaps when science overreaches what it can provide, it commits then the same error that religion commits. I wonder what you think of that.
Yeah, actually, it's also true that, of course, at least I can talk for Europe, for Belgium, we have had the 20th century and the two world wars, which raged over here and caused a lot of trauma. And how the official religion, which, was not very, especially in the Second World War, how the Catholic Church protected the Nazis, and then also what we saw after, I think at least the Catholic religion became very rigid. I know, for example, both my parents went to Catholic boarding schools where run by my dad by priests and my mom by nuns, and I know more about, my mom talks a lot about this and how those nuns were very rigid and very, and so how those children who went to those schools saw how nefarious these effects of this Catholic dominated culture was harming actually people. And then of course now we know all those stories about sexual abuses that have come out of the last decade or something, on the abuses of children by priests from the Catholic Church, and how the Catholic Church has been covering that up all the time, and so those are all very traumatic experiences. And of course, when you go through something traumatic, the person who then you reject everything that has to do with that trauma, and so people have rejected very strongly, at least here. I don't know if it's the case in all the countries, but at least here in Belgium, there is a very big rejection of the Catholic religion. But then at the same hand, then you see it's like there is some vacuum, and then people have nothing to believe in anymore. And so that I would say that's more my parents' generation who has, been drawn away from religion, and then younger generations like my generations who are more looking at something to give meaning anyways. And we see that science has sort of science with a big S has sort of replaced religion with a big R, and it's like the new religion. and maybe that's not it. People are looking for meaning, and they don't find enough meaning in what science knows right now, even though I think scientific research has been doing some very interesting things recently. They start to research people who have near-death experiences and things like that. So I think there's an opening up of the science of consciousness, which can be, in the future will be I think we still have a lot to discover in the future, but people right now, there are a lot of people who are really searching for some meaning, and this scientism way of explaining the world is not enough. And so people are drawn to, for example, to Buddhism, but also to all kind of weird type of cults, and so there's also a danger in that, some new age type of ways of looking at things, and because people are confused and they don't know what to believe anymore, and now we see people who reject science, who start to say, well, scientists or medical doctors have heard too much, have done too much harm to me, so they reject completely what science has to say. And so it's like we go from one extreme to another, and we are not capable of finding, the right balance, the middle way, where we have some sort of trust in something bigger that, goes above us, but without being blind, without falling for blind trust in something. Maybe that's one of our problems, is that we risk to fall for blind trust too easily, or I don't know.
It's so fascinating to talk about this with you. And it seems to me that perhaps the problem in some level is this dogmatism.
Yeah.
This dogmatism. We can pit the worst of religion against the best of science, and then religion will lose. We can pit the best of religion against the worst of science, say scientism, for example, and of course, we'll see a different result. It seems the problem is the dogmatism. If science falls into dogmatic scientism views, it's not so good. If religion, when it's applied, and truly it has been, we know this, in dogmatic ways, it can become really very inhuman and quite toxic. And so this seems to be, this sort of interaction between these two forces seems to have characterized much of it, certainly Western civilization, I would say. So I wonder if the enemy, in a way, of that science and religion are so similar in the sense that their enemy is dogmatism. What do you think?
Yes, actually, I completely agree with you. I think the problem is not religion, the problem is not science, the problems are scientific dogmatism or scientism, or on the other hand, religious dogmatism. And we see that in society where the problems is the extremism, religious views who are become intolerant to other views, but also the extreme materialistic views who become intolerant of people who are religious, and, you know, push them down as saying, oh, you're being superstitious or whatever, or this really anti-Christian way of viewing things, and just throwing everything away from the Catholic Church. As I said, I grew up in a Catholic school. Well, I always went to Catholic schools. I went to a Catholic university, and this way of rejecting completely the Catholic way of looking at things, I have a problem with that, because of course in Catholic thought there have been problems when we hear about sexual abuse in the church and everything. This is really something that should not have happened, but I think the problem was the human beings who did that. And so to say I don't believe anything from the Catholic Church anymore because they have done such bad things in the past, well, then I'm like, well, when you really read the Bible and you read the New Testament and you read the story about Jesus, I mean, he's not responsible for, if you really listen to his teachings, things like abuses wouldn't have happened in the Catholic Church, and they do happen outside the Catholic Church too, in other religions too. There are stories of in other communities, like in Buddhism, there have been stories of sexual abuse. So it's happening wherever there are humans, I believe, human groups. So rejecting everything because there is one problem or one negative thing, I think it's problematic. And the other way around, to reject big pharma, reject all Western doctors. Well, still there are many people who say, I don't trust science, but when they have a problem, they are the first ones to be in the emergency room and trusting science for the doctors to save them. So, and they use science to help people. So, and there have been abuses in the scientific research, and there have been abuses and problems in pharmaceutical companies trying to hide certain side effects of certain medication because they want to sell more, or there are problems, but that doesn't mean that all the medications should be thrown away, because many of our medications save people's lives or make their lives better. And we need to be more nuanced and stop looking at this black and white and look at all the gray in between, because we are human beings. No one's perfect. So society is not perfect either. And any institution in society will have its flaws and its problems. And so I think there are good things in everything. There are good things about science, very good things about science. It has made that there is a lot of progress thanks to science, which has made our life more comfortable, which has extended human life thanks to, for example, antibiotics or whatever. But then the religion also has very good things, because I see that, you know, patients who are authentically, I'm not saying religious as an identity, as being something dogmatic, because I think that creates a problem. Like, you know, I'm a Muslim and I believe that this and that because I'm a Muslim and my family is like that. I think that becomes dogmatic also, and becomes problematic. When it's dogmatic, it becomes problematic. But really, people who really sincerely have some religious trust or experiences, it's so helpful for them and for their environment. I have friends whose grandparents were deeply Catholic people, very, very, very Catholic people during the Second World War, and they lived in a Jewish neighborhood in Antwerp. And when the Nazis started to look after the Jews, to take them and send them to Auschwitz, they hid 2 Jewish children in their house during the whole war, and they had children by themselves, and they took in their house 2 Jewish kids, and they protected those kids during the whole war, and they were very lucky because they could have been caught a few times because they have been denounced a few times by neighbors or whatever, and so the Gestapo came to their house to search the entire house, and those kids could hide and never being caught, but could have been. And so when I talk about, well, now they are dead, but when I talk to my friends, when I talk to my friend's mother and I ask her, oh my God, I don't know if I would be able to do that if I had my children and take in children from another family in my house, knowing it's going to risk the life of my entire family. And then her answer was very simple. She said, but my parents were very religious people, and they had this profound connection to religion. And for them, they didn't even consider of not taking in those children. It's just how it should be. So those religious people, and she really says it's thanks to the religion that those parents risked their life and the life of their entire family, and they actually saved lives by doing so. And I think it's a wonderful, amazing story. And so we cannot just say religion is a bad thing that we should throw away, because it helps people make very good choices and very courageous choices that I'm not sure I would have been able to do if I had been in their situation. I don't know. And then they tell you, well, if you see 2 small kids, you just don't think about it and you just do it. It's protecting, other humans, and you will just do it. But I don't know. I don't know. I need to be in the situation to know that. But they clearly say it's the religion that made them take such decisions. So religion has very good sides too.
Very interesting discussion, Dr. Caroline. Thank you for being so generous with your time. And I'd love to petition you for a sequel. There's still so much we could talk about. I'd love to also talk to you about personality disorders of various types. We've talked a little of psychosis. We've talked of these things, but I'd love to talk about personality disorders and the what occurs when someone with some sort of a personality disorder is in a religious context. And perhaps also a little bit about aberrant reactions of meditation experience and mystical experiences. We're often hearing that these days, discussions of the negative consequences of certain meditation retreats, going on meditation retreat, having some sort of transcendent experience, some sort of personality shattering or schema altering encounter somehow, and then having great difficulty integrating that. And actually, essentially, we hear reports sometimes of people having a psychotic break, actually, on meditation retreat. So what can we think of going into such a retreat? How do we integrate religious experiences of the benign and also sometimes frightening? How can we integrate those? What's your perspective on that? I'd really like to discuss that with you.
Yeah, okay.
Are you up for that? Part 2?
Yes. Okay, yes. I think,
great.
Yeah.
Well, thank you for being so generous with your time. This has been enormously fascinating. Dr. Caroline Van Damme, thank you very much.
Thank you very much. Bye-bye.
Thank you for listening to another Guru Viking podcast. For more interviews like these, as well as articles, videos, and guided meditations, visit www.guruviking.com.